Good evening, everyone. And on behalf of AANA, I'd like to welcome you to the Wednesday webinar series. This week's topic we're covering is meniscus repair, preservation, and transplantation. My name is Aaron Critch from Mayo Clinic in Rochester, Minnesota. We'd like to recognize and thank our co-sponsors for this evening's program. This includes Arthrex, DJO, JRF Ortho, and Kaibo Medical. We'd also like to recognize that we're featuring faculty from the Mercury Study Group, that is the Meniscus Repair, Conservation, and Restoration Group. Just a couple of housekeeping items for everyone. It's important that you mute your computer audio and also turn off your video on the webinar screen. We are recording this and it will be made available. If you have any questions at any time, please feel free to use the chat graphic, find my name and type in your question and hit enter. I'm happy to integrate questions within the presentations, and also we'll have time at the end of the session this evening. So we want to make sure that your questions get answered and this is relevant for you. Delighted that we have three outstanding presenters with us this evening. The first is Dr. Seth Sherman at Stanford University. Seth is a team physician for the football team and also serves as the fellowship director. Next is Dr. Al Getgood at Fowler Kennedy Sports Medicine Clinic in London, Ontario. Al has a very complex knee practice, and we follow the science very closely, and he's had very much impactful research in this. And then finally, our president of AANA, Dr. Brian Cole, needs no introduction at Midwest Orthopedics at Rush. It's amazing that success is usually measured in the hundreds, but now he's over 1,000 papers, over 2,000 lectures, and over 20,000 surgeries. So we look forward to learning from his experience and his pearls this evening. Here's our agenda. Seth will lead us off talking about root repair and horizontal repairs. Al will then take over and give us his thoughts on radial and ramp tears. And then Brian will give us his thoughts and experience on his 25 years of perspective for meniscus transplantation. We'll present some cases if there's time, and we'll also take questions at any time from the audience. So please remember to use the chat function to send those in. Without further ado, Dr. Seth Sherman is going to start talking about root repairs and complex repairs. Seth, take it away.
Aaron, can you see my screen?
I can see your screen and hear you great.
Excellent. Well, I'm really excited to be here with you guys. It should be a great hour. My disclosures are online. So Aaron's kind of alerted us to these medial meniscus root tears, maybe an innocuous low energy injury. You follow these patients, and at 6 months, you might see rapid progression towards joint space narrowing, even bone on bone at a year, requiring a uni. So that's quite scary in a select group of patients. Brian's similarly alerted us to the valgus active female, like this patient with a horizontal lateral meniscus tear that was trimmed. And what we see is rapid progression towards bone on the PA flexion view and chondrosis. Again, something that should raise our index of suspicion. We looked at this in AJSM this year and showed a significantly higher reoperation rate after meniscectomy. That was in almost 30,000 patients versus repair. And meniscectomy more likely to undergo same-sided meniscus surgery, meniscus transplants, and total joint arthroplasty. So I'm here to challenge the classic dogma that these complex, horizontal, older, red-white revisions can't heal, and frankly, to try to expand our indications for what I'm talking about is really almost up to 50% of tears, so complex roots and horizontals. So medial roots are important because a root tear is equal to a total meniscectomy, and repair can normalize those forces. On the lateral side, Dr. Laprade has also showed us that repair can normalize these forces. Both medial and lateral roots also have implications in the ACL world with regard to sagittal plane translations and rotational stability as well. When we talk about horizontal cleavages, we're really talking about implications for leaflet resection versus repair. And frankly, if you look at a tear, you look at a partial or complete resection biomechanically versus an intact meniscus or repair, you can see profound differences. There are different types of root tears. Those medials, really more the older degenerative, lower energy trauma. These are isolated type tears. Laterals happen in younger patients, acute lesions, high energy trauma associated with ACLs. These medial roots we can talk about and consider fixing in certain circumstances. Those lateral roots in our young athletes with ACLs, I think we should fix at all times when we recognize them. On the horizontal cleavage tears, medial, again, older, degenerative, posterior horn, sometimes masked underneath some sort of a complex pattern. Lateral, these younger, can be post-traumatic with a painful parameniscal cyst, as you see in that MRI. Root tears require a high index of clinical suspicion. You need to be looking for it, and then you want to confirm by MRI and arthroscopy. It is likely seen you, so you must ask, have you seen it? There are clues on the axial, such as these radial splits. There's also good clues on the coronal MRI, vertical defects, extrusion of the meniscus, and the ghost sign on the sagittal. Lateral roots are way more challenging. They're less well visualized. They actually do not extrude in most cases, and up to a third can be missed on MRI, which means at our ACLs, we must be ready to fix these every single time. Here's a young athlete, an acute traumatic ACL tear. You can see here a complete avulsion of the lateral meniscus root that needs to be addressed to help restore rotational stability to that knee joint. So indications for roots, I think these acute traumatics, we should always consider fixing them. The chronic degenerative, our indications are clearly evolving. We must know before we go. That means your standard weight-bearing x-ray series every time and a mechanical axis view if you're really on the fence deciding between repairability or not. Medial meniscus root repairs don't work with uncorrected varus greater than 5 degrees, untreated chondrosis greater than 3, uncorrected instability, or with joint space narrowing. I think there's controversy, and we can discuss relative contraindications regarding obesity, whether patients can comply with a limited weight-bearing regimen, and whether we should have them undergo this if patients are not very active and high demand, if there are more sedentary patients. Rob Leprade showed us that restoring anatomy is key. If you're off by even 5 millimeters, that is going to lead to aberrant contact areas and pressures. We're just not getting the job done. So we really need anatomic reconstruction of the meniscus root. Fortunately, there are excellent proprietary systems that can get you in the ballpark and get you to the right spot, but there's nothing like anatomy to guide us. For me, I tend to use a retro-cutting device, as you see here, making a small socket at the meniscus root. Then we use a variety of suture passage devices. These days, I'm typically using luggage tab type sutures and suture tape, but we can discuss configurations, usually 2 to 3, depending on tissue quality and tear location. Suture passage, as you see here. So getting ready to shuttle, using a cannula so that we don't have suture bridges. And then it's all about just shuttling transosseous to the anterior aspect of the tibia, tensioning, making sure that that root is reduced throughout the range of motion arc, and then fixing with your desired fixation on the tibia. For me, at this point, it's suture anchors, although there's compelling evidence and more interest in button fixation that we may discuss. Moving to horizontal cleavage, really have had some novel all-inside techniques to provide what we call circumferential compression, or a hay bale technique. This is a young patient with a ACL and a lateral meniscus horizontal cleavage tear. So what we can see is that we can pass this circumferential compression type suture. You can march along and do this at 2 to 5 millimeter clips. I think my tendency now is to do more than I did in this video, but you can see after the ACL coming back, and you can see nice compression. You can put a biologic, if you so desire, inside that pita bread sandwich to help with healing. Here's a young athlete, painful anterolateral tear with a parameniscal cyst. And so for this one, it was an inside out technique, needed a 70-degree scope to really see that far anterior. And you can see flanking that with some attempts at biology to try to augment meniscus healing for this isolated tear. Root repair outcomes are quite good. The repair groups have superior subjective scores, less radiographic progression of arthritis, and 0 versus 35% conversion to knee replacement. This is a more recent study, 50 knees, 6.7% revision rate, significant improvements in patient satisfaction across the board, medial roots equal to laterals, young age equal to these older age patients. Horizontal cleavage repairs also have good outcomes, mimicking those other tear patterns, the more classic patterns, 80 to 90% good or excellent outcomes. Here's a study showing 30 patients at up to 8.5 years, 15% failure, 91% return to sport. This is the Stitch study. That was a multi-center prospective clinical trial, 91% success rate at 12 months, 8% reoperation rate, significant improvement in all patient-reported outcome scores, complete healing on second look needle endoscopy or arthroscopy in 10 of those patients. And lastly, Aaron wanted me to touch on flap tears. So here's a 17-year-old contact athlete, 1 year of mechanical symptoms and effusion. So in this young athlete, I'm going to try whatever I can to try to repair the meniscus. I think meniscectomy for that large flap may have significant detrimental effects and open up a Pandora's box for this athlete. So it's worth a chance. For me, I have all tools in my arsenal on deck. So the first thing I do is try to create an apical stitch to try to reduce that flap as much as I can. And you see here, now that kind of propped the tear up. And so I do an all inside underneath. And when I tension the all inside, now it sets me up for some circumferential compression. I can do 2 passes, one in the periphery, one in the central. And that really helps to close down that vertical longitudinal component. And then lastly, I placed another apical stitch, and I can pass this on either side of a previous suture, sort of like a rip stop, to help provide support, particularly in situations where there's imperfect tissue quality. And so this can take some time and doing, but I'm putting it in a relative position with good stability. And so I augment these with microfracture of the intraarticular notch, as you see here. In isolated cases, this is my go-to biologic of choice. And you can see I've trained the marrow elements to go into that lateral compartment. And we'll get a second look now at our flap tear of the meniscus. We can touch on rehab in a discussion, but for this one, I'm going to have a conservative rehab. I may not even move them that first week or so. I will do foot flat type weight bearing as I do for my roots, my radials, and my complex tears, which is very different than my buckets or my classic vertical longitudinals or the horizontals, which I do allow early weight bearing. And lastly, here's a 40-year-old nurse. She has a chronic ACL tear I'm fixing and this really complex medial meniscus tear. I'm very concerned if I take this out, we've lost our brake stop and our secondary stabilizer. I have the biology of the ACL to give me a boost, and I go for meniscus repair. Again, this is an all hands on deck, trying to piece together the periphery initially using a variety of all inside devices. You can see my first pass, which is quite peripheral. And then, we'll continue marching on, taking what the tissue gives us with a variety of either 1-pass circumferential compression hay bales or 2-pass suture technique. And then lastly, once I've stabilized the periphery, I use a couple of all inside sutures, as you see here, and try to get that meniscus in a relatively good position where it's now protected with the stability of the ACL with reasonable biology and a chance to heal. And here's kind of the final, what that meniscus looked like. You can note this was a very tight compartment. I am pretty liberal with trephination of the MCL so that I can see and do and repair these menisci. And so hopefully I've showed you that you want to limit your number of partial meniscectomies. They can lead to OA and poor functional outcomes. We want to have a high index of suspicion, particularly for these root tears. You need to know before you go so we can make good clinical decisions. And then we want to err on the side of meniscus preservation if at all possible. For me, this is the roots, horizontals, flaps, complex that I showed you here. Al's going to show you radials and ramps. And overall, if you learn nothing else from this hour, we want to try to save the meniscus. And I thank you very much for your attention and look forward to hearing the other speakers and having a good conversation. So I'm going to stop sharing now, and hopefully we can move on to Al.
Seth, that was fantastic, and thanks for being on time. While Al's getting set up here, a couple questions from our audience members. One is, how are you determining that 5 degrees of malalignment as a threshold for your root tears?
Yeah, I think, I mean, I use mechanical axis views, and so I can just measure mechanical axis deviation from those. I think an important point that we might discuss in more detail is just physiologic varus versus asymmetric varus, and when you're prompted into action. These are numbers based on some studies I didn't have time to get into that guide us, but they're not absolute. So I think lower threshold to correct alignment in young active patients, higher threshold in symmetric varus, and when it's on a borderline.
Great. And then just quickly, you showed preparation of the bone during a root repair. Do you do anything to prepare the meniscus for healing to the bone?
Yeah, I mean, I'm always debriding it with a shaver. I use a rasp on the synovium, so a ball rasp on the synovium and the meniscus, and then obviously with your suture passage, I think that can create some access channels as well. And then I use a curette in addition to that retro cutter in most cases to kind of leave a bed, not just at the root, but a little more, basically would be more medial in the medial meniscus.
Great. Well, thank you, Seth.
Yeah.
So next up, Al is going to give us his perspective on meniscus radial and ramp tears. Al? Al, you need to unmute.
Yep, you got me now?
We got you.
Thank you. All right. Thanks, Aaron. Thanks for the invitation to be with you this evening. And I'm going to be talking on radial and ramp lesions. Okay, so some disclosures, none of which are relevant regarding this talk. So I thought I would just start with this case. This is a 23-year-old girl, obviously playing volleyball, lands awkwardly on her right leg, knee gives out, and she sustains an acute ACL, MCL tear. And we get this MRI post-injury, and we can see not only she's got the MCL injury and the ACL injury, but you can see she's got this really significant posterior third lateral meniscus radial split. So the meniscus is completely truncated with a significant impaction injury in a lateral femoral condyle. And these are some of her arthroscopic pictures. And this is a really challenging problem to address. And I'm just going to use this as a sort of a background, and we'll get to actually what we did a little bit later. So what is the impact of radial tears on meniscus? And there's been so many studies that have looked at meniscus function, and we clearly understand the anatomy of the meniscus and the circumferential collagen fibers that really can translate compressive forces into hoop stresses and then can protect the joint. And I find this study really quite interesting, looking at sort of essentially where the position of a radial split occurs. And what we see using tech scan contact pressure mapping is that we see that through it from extension through the greater degrees of flexion, the peak contact pressure increases as you get into deeper flexion, as the tear goes from the mid-body round to the root being worse. And equally, the contact area also diminishes again as we go into greater degrees of flexion, going from more mid-body round to the posterior root. So these we understand that these tears really do behave similar to a root tear. They do behave like a total meniscectomy. So really, we've moved. The discussion has changed. We're not talking about should you repair a radial tear. It's more a case of how do we, and what's the best technique to be able to using that to try and preserve meniscal function. There've been a number of studies. I mean, Frank Noyes has been a big proponent of radial tears for many years, but more recently, over the last 5 years, we've been starting to see some new techniques coming out. I think one of the more promising techniques is the use of a ripstop type suture, or the tie grip that has been described in Japan, and even some people are talking about it as a hashtag type suture. So I think these are something that can really be helpful. When you're doing any of these types of repairs, of course, we use our standard, we need to be facile with a number of different techniques. So classic open approaches are required for inside suturing, either posteromedial or posterolateral through our standard windows, and also utilizing contemporary meniscus repair techniques from a point of view of where we're passing our sutures, using ipsilateral, contralateral portals to avoid increased risk of damage to neurovascular structures. So this is an example just of a ripstop or tie grip type repair of a radial split. This one hasn't gone all the way out to the periphery, but in this case, I've just essentially put two vertical sutures in place first, followed by two horizontal sutures, and using those as a tie grip or a rebar, whichever way you want to describe that. And then these sutures are tied over the capsule. On the medial side in particular, Laprade has popularized the option of using a transtibial technique. This was one of their later publications, which looked at the combination of both a two-tunnel transtibial technique as well as these sort of tie grip type ripstop sutures. And the mechanical load to failure was significantly increased if the hybrid tunnel plus the ripstop vertical mattress sutures were included. So certainly we can make much stronger constructs when doing these repairs, and really we just need to understand what we can and can't do. So this is an example. This is a different patient than the one I showed. This is a 34-year-old female who had an ACL tear, and we find this tear pattern. And this is a really complicated tear pattern. It's not your classic root tear. It's it's at least 1 centimeter away from the root, and there's a flap component to it with with a vertical component to it as well. So this is a really, for me, was a pretty challenging tear to repair. And in this instance, I utilized a single tunnel technique, so essentially using a curette to get down to through the articular cartilage down onto bone. And then from that position, then essentially we can drill a tunnel to that position and pass some sutures through the leaflets using a standard suture passer. So this is just a high strength suture being passed in a horizontal mattress fashion, going from the inferior to superior surface, and then the next throw going from the superior surface to the inferior surface. This is the second suture that I passed. And then once those sutures are in place, one can then drill a 2.4 millimeter pin using a root guide, and that will allow us then to shuttle those sutures down through that tunnel. So this is just the root guide going in, and then after passing a passing suture, we can shuttle those sutures down through that tunnel. And what's the beauty of this technique is it just helps you reduce the tear and then set you up for success in terms of being able to do some vertical mattress sutures, both either in an all inside type fashion or even on in an inside out type fashion. So lots of different options as to how we can go about trying to repair these types of sutures, or sorry, these tears. The rehabilitation is very similar to the root tear, flat foot touch weight bearing for the first 6 weeks, 0 to 90 range of motion, and then weight bearing is tolerated thereafter, but just avoiding deep squats until 3 months. What are the radial tear repair outcomes? There have been lots of studies looking at this. There's a nice study from Mayo that Aaron was a senior author on, and really just showed that one can expect fairly similar patient-reported outcomes as well as survivorship when comparing against bucket handle tear repair. So really there isn't much of an excuse for us anymore to not be trying to repair these tear types. Moving on to ramp lesions, well, it's important to understand what these are. There's been a number of different descriptions of these, but I think my interpretation of this is really both a meniscocapsular junction injury, but also probably more importantly, a meniscotibial ligament disruption. They've been described. Steve Bolland from the UK described these quite a few years ago with about a 10% prevalence, but more recently, depending on how one looks for those, whether you're going from the anterior portal underneath the PCL or creating a posterior medial portal, the prevalence can be up to 40%. The number of classification types that have been suggested, and certainly types 1 and 2 would be suggested of being partial tears, and really only thinking about maybe repairing those that have increased rotation or translation, which I'm going to get to in a second. So these are the types 3 and 5. Diagnostically, MRI scan will give you a bit of a clue. So you may see some high signal in the posterior border of the medial meniscus, as well as a posterior medial bone bruise on the tibial plateau. But really, the gold standard's got to be looking at it intraoperatively. And as Seth said, with our root tears at the time of arthroscopy, if you don't look for them, you're going to miss them. So the key here is having a look either through the Gilchrist approach to the posterior medial recess, or doing a posterior medial portal, or even both if you're not sure. Why should you think about repairing them? Well, there's some pretty good biomechanical data that would suggest, this is from London, England, which would suggest that if you do an ACL reconstruction with a ramp lesion in situ and don't repair it, you're not able to restore the normal kinematics, and that only occurs when the meniscus repair is performed. And then when you translate this type of work into the clinical setting, a study from Roman Sale that looked at about 200 plus ACL reconstructions over a period of time, looking at their laxity pattern, showing that ramp lesions were significantly associated with a higher grade of pivot shift. So maybe that's a concern, obviously, for us. And Laprade has shown some nice outcomes, suggesting that by doing a ramp lesion repair along with an ACL reconstruction, you can anticipate to have similar outcomes as though you have an isolated ACL reconstruction. But of course, there's always, you got to have the yin with the yang, and there's the opposite of this would suggest this is a biomechanics study from Pittsburgh, where they found by creating a significant ramp lesion in the back of the knee, they actually didn't find any significant difference in kinematics or forces applied to the ACL in lesions less than 25 millimeters. So they would suggest that the lesions less than 25 millimeters are stable and don't need to be repaired. We look at the clinical data maybe associated with this from HSS, again, suggesting that unrepaired stable lesions really don't have a big impact on anterior or rotatory laxity. And this is really suggested again in systematic reviews and a lot of other studies. But I think the key message here is that patient-reported outcomes tend not to be very different when you look at a ramp lesion repair. But really the outcome of choice has got to be ongoing rotatory laxity and ACL failure. And when we're dealing with young patients, we know we've got a high failure rate. So my argument would be that if you've got increased laxity, young patient, high risk of failure, there's no real downside in doing a ramp lesion repair. So this is an example, a 24-year-old football player, 6-month-old ACL injury playing flag football. He had high grade, he had a grade 2 lock, 1 grade 2 pivot shift. He had a very small grade 1, grade 2 MCL with positive dial test, and that was more of an anteromedial rotatory laxity as opposed to posterolateral. Radiographs unremarkable, apart from a very minor side-to-side difference in his valgus stress fuse, indicative of a deep MCL injury. Here's just his sorry, it's just a video showing his increased anteromedial rotatory laxity on the dial test at 30 and 90 degrees. And then when we put the scope in the knee, you can see there's a little bit of meniscofemoral gapping. We can't really see very much from the anterior view, and when we probe that, there really wasn't much going on. But when we bring the scope underneath the PCL, into the posteromedial recess, you see that large ramp lesion. So with this combined with the increased laxity, this led me to do a repair. A number of different techniques. You can do a posteromedial portal, is the technique that was shared with me by Tom DiBardino, using a suture passer, just a hook suture passer, and then a cinch suture, which can nicely bring the meniscocapsular junction back together. For me, I like to do actually a suture repair from the front using an all-inside device. And the reason for this is I really want to try and grab the inferior meniscotibial ligament. So my first passage, looking through underneath the PCL as I pass my all-inside device into the capsule, then through the superior surface of the meniscus, and that will reapproximate the capsule to the back of the meniscus. And then the next stage is we'll go to the anterior view and we'll actually do an inferior based all-inside passage, again on the inferior surface of the meniscus, and then into the meniscotibial ligament, and I'll put 2 sutures on that side. And I've been very satisfied with the results of that repair. So in summary, again, I think reiterate what Seth has said, meniscal preservation is of paramount importance. We know radial tears behave like total meniscectomy. Lots of techniques to help us achieve the desired results. And really, we want to try and repair unstable ramp lesions, again, with the aim of improving our ACL outcomes, particularly laxity results and failure, rather than not just patient-reported outcomes. Thank you very much for your attention.
Well, thanks, Al. That was terrific. As you're unsharing your screen, we're getting Brian up. We'll ask you a couple questions from the audience here. One is, any role for an unloader brace with these radial repairs in your rehab?
Yeah, I mean, even in the medial meniscus, even in the neutrally aligned limb, I think there is a role for an unloader brace. Your center of mass is still medial to the center of rotation of the knee, so you're always going to see an adduction moment in that medial compartment. So I think anything that you can do that could potentially help the outcome of that patient is worth doing.
And then the second question is, the case you showed with the flap tear in the back, you placed a tunnel that was kind of non-anatomic from the root. Do you have any concerns on the longevity in terms of, function of the hoop stress or function of the mobility of that meniscus?
Yeah, on the medial side, I have less concerns. I think it's always a concern, but we know you're not going to get as much meniscal excursion on that medial side. On the lateral side, I'd be a little bit more concerned, and try and avoid using tunnels on the lateral side. But sometimes with these complex tear patterns, I really just want to be able to get some approximation of the tissue. And if it means drilling a tunnel, then that's what I'll utilize.
Perfect. Well, thank you very much. So now we'll move on to Brian. Brian's going to share with us his 2.5 decades plus experience with meniscus transplantation. Thanks,
Sounds
Brian.
that sounds like a really long time. Can you hear me okay? Seth, give me a thumbs up if you can hear.
We can hear you great. Yep.
Yeah, 2.5 decades. All right. So
Once a fellow, always a fellow.
No, not anymore. Clearly, you're doing things you didn't learn in fellowship. We'll have to talk about that. So I'm proud of you. So, okay, I'm going to just give an overview and be very concise about some of the things that we've learned over the last 25 years in meniscal allograft transplantation. And like all of us, our disclosures are with the Academy. So what's interesting, and I think it's important after hearing the last 2 lectures, that there are probably a minimum of 500,000 meniscectomies done a year. And we only do about 1,500 to 2,000 meniscal transplants a year. Now, obviously, when these meniscal meniscectomies are coded, they're coded like 29881 and so forth, and they're not always the kinds of patients we're describing here. But the point is that most patients do very, very well after meniscectomy. And I think that's important, especially after hearing Alan's talk about ramp lesions. I think he did a really good job discussing the fact that benign neglect is still an option. In some respects, technology and the sensitivity of our diagnostic skills and imaging has driven a lot of our decision making. I'm not saying it's the wrong thing, but I think it's important to remember that when you look at these numbers, they're pretty sobering. 500,000 meniscectomies, we do 1,500 meniscal transplants a year. And if I told you how many patients have gone to meniscal transplant in my own practice, I'm thinking around 10. In other words, you do a meniscectomy, how many actually come back saying I got problems in the future? So I just want to set the stage for what most commonly happens. The absolute indications are what you see here. Absent meniscus, they have pain and or instability, but I'm going to tell you that a very reduced frequency of doing meniscal allografts in the setting of instability. And I can explain why if we have some time at the end. But the most important thing is to think of these patients not as only being meniscectomized, but they have other comorbidities. Most commonly, they're malaligned, or they may have ligament deficiency at the same time, and obviously a cartilage injury. This is one of the most important slides. This first study in AJSM suggested that maybe we should do meniscal allografts early in the absence of symptoms. I would tell you the study was underpowered. It was unmatched. Meniscal transplants don't last forever. They're a scaffold, maybe 8 to 10 years. Once you take a patient who is meniscal deficient and then put a meniscus in, they now must live a life of meniscal dependency, right? So they have to decide risk benefit of getting back to high level activity. So to go ahead and just do one because you think it might make a difference in terms of counterprotection, I think you still have to think twice about that decision making. Basic tenets. An extension x-ray shows you one thing, but a flexion x-ray shows you another. If you look at this patient's left knee lateral compartment, you would never predict that they'd have that amount of joint degeneration, but put them in flexion and that's what you get. This is a 35-year-old who we used their extension view, and shame on me, we were measuring the meniscus. You can see the measurements here, and then we come to surgery, and that's what they look like. That patient, you hope that you never thawed the meniscus, because that's not a good patient for a meniscal allograft. What about sizing? I would just say that if you're going to do this operation, this is a good article to read by Pollard. We've looked at it by age, gender, height, and all these other things, but I'm going to tell you that I still use Pollard's article back in 1995. Which looks at markers that you put on the knee, and essentially, you correct for magnification, put a 1/4 or 100 millimeter marker on it, and you just correct for it. And you're not going to remember this. Maybe you can even screenshot this if you're going to do this. It just gives you a sense of how you size. The tissue banks use this largely, but you really want to do your own measurements and compare to what the tissue banks give you. Size does matter. I will tell you that up to about a 10% size mismatch is probably acceptable. I would rather have a larger meniscus than an undersized meniscus. I can do more technically to actually adapt to it. Undersized meniscus, I think, is a bigger risk of causing abnormal tibial-femoral contact forces. There's a lot of discussion about maintaining bony insertion. Clearly, if you look in Europe, you can get a very good result with just doing a soft tissue implant. The literature in the United States has been based upon time equals zero. Let's take a meniscus with and without bone, look at the tibial from contact forces and see what it looks like. It doesn't look good, but that's not what's happening when you actually sew a meniscus into a tunnel. It probably behaves like you had bone. So if you're planning on doing these with soft tissue only, I think there's reason that there's literature to support that decision. These are the various techniques. Bone plugs were what was initially described, but bone plugs are difficult on the lateral side because the anterior and posterior arms are so close together. So that's where the dovetail technique and bridge and slot technique came in. Jack Farr and I years ago looked at a technique where we can actually just take a bone bridge. And one of the criticisms of this technique is that we would actually violate the tibial eminence and that there would be increased contact forces there and that'd be a problem. But I think when we used to do bone tunnels, we would actually get rid of the tibial eminence altogether. So the good news is that there's very little weight in the relatively normal knee that's distributed across the eminence. And we found that we were able to restore tibial femoral contact forces with the bridge and slot. So I like the technique because it's very reproducible and it's very efficient. So we do a standard meniscectomy. We'll typically leave a little bit of peripheral rim. I use a burr to go down the full burr depth through a transpatellar tendon approach. I then have a depth gauge that just sits in that, and then a couple of millimeters deep to that, maybe 5 to 7 millimeters, you drill a guide pin front to back. If you're uncomfortable, just use fluoroscopy. You don't want to break out the back. And then we ream it with a 7 millimeter reamer. So you're basically creating a tunnel anterior to posterior with a very thin cartilage rim on top that you break away with a box cutter like you see here. And then there's a series of rasps that create a rectangular slot. Al did a nice job showing the dissection from meniscal repair. This is a very easy way to introduce the meniscus. This bridge and slot technique, I can basically prepare the meniscus by the time the patient is draped and prepped. It's about a 5-minute preparation, and you don't have to take any measurements from the knee. The other reason I like it is that you can do osteotomies and ACL reconstructions, and you don't worry about dodging tunnels and so forth. So this is just the meniscus going into place. And I use all vertical mattress on top and bottom, typically non-absorbable sutures. And so how do we do? What can you tell your patients? I think the thing to understand is that most of us are used to quoting literature and saying, what's the MCID and, and so forth. But there's this concept of PASS, what does the patient actually appreciate as being a clinical benefit? And that's really what they're looking for. But if we turn to the literature and say, what do all these level 4 case series tell us? And what all these systematic reviews tell us? Many of the individuals on this Zoom call have contributed to these articles. If you look at Leishholm scores, they generally fall between 80 and 85. But if you look at all the activities for Leishholm in the United States, we don't do it. Al does these in Canada, but we don't do a lot of these in the United States. But the bottom line is Leishholm is, I'm referring to Tegner, forgive me. Leishholm is an outcome score that we can identify with, but the Tegner score, I'm not sure that curling and things like that Al does are the things that we do in the US. So whether it's relevant or not, I'm not entirely sure, but they average about a 5 out of a 10-point scale. If you look at some of the other outcomes that we see, these are 14 studies that were looked at. The overall satisfaction rate, which is sort of like a PASS outcome scale, what's meaningful to the patient, 81% of patients after undergoing meniscal allograft said they were satisfied in these 14 studies. The other thing that's interesting is that, like a lot of other cartilage procedures, these injuries happen in active patients. And you say, look, what about return to sport? My answer to my patients is that we have about a 75 to 85% success rate in returning someone to the sport that they wish to go back to. And what has been surprising over the years is that it is very, very rare that a patient has injured their meniscal transplant to the point where even if I had to go back and trim and do something, that they have been unable to get back. And that's in some very high level patients. Intuitively, I would tell you that would not have been my prediction, but just from my anecdotal experience over more than 20 years, we've had very few re-injuries when patients go back to high sports. I will tell you that they often decide not to just because of the relative risk and they've gone through enough and they're just happy to have pain relief. But if a patient is in a certain category, we will have that discussion, and some of it is just intuitive in nature. Adolescents, we've now broken down our more than 600 patients and said, look, let's look at all these different groups and what can we teach people and learn for ourselves, actually. And meniscal allografts in adolescents where there is open growth plates, it can be done. The good news about a slot is you stay above the growth plate, and the outcomes are the same as they are in adults. Complication rate cumulatively is very low. The cited complication rate from 20 studies was about 10%. I think it's kind of what you cite as the complication that you're going to document in addition to how long the follow-up. I think the most common complication is twofold. Patients who come back in the first 1 or 2 years are not doing as well as they want to, so we rescope them. And I'll show you our long-term data. We found that 25 to 35% of people will come back for another scope, and about 65% of them actually do well with that scope. The second group are those who just degenerate over time. This is not meant to last forever, and that's why I would tell you that if it takes 10 to 15 years to develop arthritis after losing your entire meniscus in, say, 50% of the population, and then only 10 to 20% of those people ever become symptomatic, you have to ask yourself, is putting a meniscus in the rational thing to do in an asymptomatic patient? So I just want you to think about that before you pull the trigger too early. This is a 7-year follow-up study that basically had an 88% success rate. This was a good study just because it looked at how and why we fail. And it's a pretty heterogeneous group, and you can see the survivorship curve there on the right. I think the take home from this study is that we had a 32% reoperation rate. 60% of them were debrided. 65% of them actually did well after their debridement, but the odds ratio for failure was 8.4. So if you do go back, if you make that decision to go back, this is a population that doesn't fare as well in the long term. So it is sort of a negative prognostic factor. But that being said, your decision to go back and rescope and my decision may be very different, but this is what we found in our series of patients. This sort of gives you a sense in the most conservative way, what should patients expect? This is the sort of the survivorship. If you start taking all these studies that are published, even though many of them are level 4, where we're at. And I feel pretty good about recommending this operation, even though it's not lasting forever. But we're not doing it for preventative reasons. We're doing it for patients who have pain and activity limitation due to that pain, due to a single compartment. And if you are cognizant of the comorbidities such as malalignment and chondral disease, and you repair that stuff at the same time, and you don't do this in a ACL deficient patient, I think you can expect results that are pretty predictable in the near and intermediate term. What about revision? We have a much bigger series of revision now, but I will tell you, you can revise these patients. We have a number of patients that came back after 4 to 6 years, for example, failing. As long as you address the comorbidities that developed over that time frame, you can get a satisfactory outcome in a revision situation. And then finally, we're starting to look at other factors to say, look, what predicts a good outcome and a bad outcome? And as you might expect, our bone marrow lesions were inversely related to clinical outcomes following isolated meniscal transplants. So that was somewhat interesting, and I'd say pretty intuitive. This is one that I think is worth taking home. If you have a patient who has tibial disease and you treat the femur and you do the meniscus, those patients actually do very well if you neglect the tibial disease. It's a lot like the shoulder, I think, where you have humeral head disease and they have some glenoid disease, and you kind of ignore the glenoid disease and treat the humeral head, maybe with an allograft or maybe with a surface replacement. Those patients actually do very well. The tibia is very well tolerated. If you look at your patients who come to you with isolated tibial disease, the challenge with isolated tibial disease is that we don't have a lot of options to treat them with. In our experience, when you treat them in something as even as simple as marrow stimulation, thankfully they do pretty well, because doing an allograft for a tibia is holy hell, right? So my gut is that over the last 20 years of all the tibial defects we treat, patients tolerate tibial disease very well. And to say that it's an absolute contraindication to doing a meniscal transplant, I think isn't true. So you can microfracture, you can debride them, but you don't have to go overboard to treat it as long as you treat the femur, treat their malalignment, treat their ligament deficiency at the time of doing the meniscal transplant. I believe you can get a good result. I think this was perhaps mentioned before, but are these chondroprotective? I really have to credit Tim Spalding, who has had a couple of major initiatives in this regard. And I think there's some evidence to support that it might be chondroprotective. But if you ask my level 5 opinion, it's not enough for me to do it early. I'm not going to take a meniscal independent person who can do everything they want to do and make them meniscal dependent by giving them an allograft that I don't know will make a difference in their life. And finally, I have to really thank Alan for getting this initiative off the ground. Everyone on this call might have been part of this for the IMREF, for the consensus statement. This is the take home of those of us who do lots of meniscal transplants. The indications were pain in the presence of a functional meniscectomy, at times at the time of revision ACL, and always do concomitant articular cartilage repair. Not routine in the asymptomatic patient. Have great caution in the untreated patient with chondral disease or patients who have grade 3 or more. Non-irradiated, frozen, or viable meniscal allografts are options. Most of us don't do fresh allografts. We do non-irradiated or slightly irradiated frozen. MRI or radiographs can size. Each one works. What's also interesting is that there is no superiority of one technique over another. Absolutely have a low threshold for osteotomy and have some degree of caution, or at least counsel your patients responsibly for return to sport. So in conclusion, I think, like anything we're talking about here, proper indications, earlier is better. But I would tell you that too early may not be warranted. Patients reach minimally clinically important differences in multiple patient-reported outcomes in 70, 80% of what we see. More importantly, I think, is that patients are satisfied about 80% of the time. Just choose them wisely. The other thing that I've learned is you can get athletes back to play. Survivorship is a minimum of 50% at 10 years, but I go on the record when I talk to my patients, when I indicate them, I tell them they've got about a 75% survivorship. And what's good about this is it's done in an outpatient setting. It's become very reproducible. I think if you can do a meniscal repair or an ACL, you can do a meniscal transplant, and the complication rate is very low. So thank you for your attention, and I appreciate Aaron and Seth for putting this together tonight, and Matt for making it possible from a technical point of view.
Well, thanks, Brian. That was really fantastic. A lot of perspectives there. We've got some questions rolling in from the audience. So one is, you mentioned that in the setting of instability, you're maybe not considering transplant of the meniscus as often. Can you elaborate on that?
I will tell you there was a time where allografts or revision ACLs would fail over time and present, and they were meniscectomized, and they had no pain. And I was routinely doing meniscal allografts, especially on the medial side, based upon a number of studies that have shown resistance to anterior translation, and it might protect the ACL. I think that what's happened for me anyway is that if you're going to do a revision ACL, you got to make it the most perfect ACL ever. And I will tell you that probably the hardest operation I do is a revision ACL meniscal transplant, because no matter how you choose to do your meniscus, it's typically medial. You have to change, or at least there will be technical challenges if you use tunnels versus a slot, your technique. And I think that I've gotten better at figuring out why people fail their ACL. And I'm doing, things I've learned from Alan, ITB tenodeses that I hope I'm doing technically correct. Just doing more and looking at sagittal slope and osteotomies that I think are making the difference to do a revision ACL and get a good outcome. If they have pain, it's a different answer. I don't have a problem doing a meniscal allograft and an ACL. But if you take that patient who comes back to you with recurrent instability after having an ACL, and you want to rely on the meniscus, but do a poor job at your ACL, I don't think that's going to solve the problem. I might be wrong. And again, we talk about level 5 and so forth. And I will tell you that, in practice more than 20 years, I'm much like some of those cases that Seth showed. If we have time to talk about them, I think it would be great to talk about it. And I love these because I learned a lot from you guys in seeing what you're doing. But it's worth a sobering discussion about how you choose a patient with that flap tear and so forth. If you said, tell me what you learned from your experience in over 20 years, that's something I've learned over time. We have better ways to revise an ACL now. And if I can't do a perfect ACL revision because I'm trying to get a meniscus in there, I don't want to do the meniscus. I'd be interested to know if other people are routinely doing meniscal allografts at the time of an ACL. But if you asked me 10 years ago, I would say, yeah, it makes sense. I'd read this paper. Freddie Fu showed me this. Forces go down. It's less anterior translation. If I could do an osteotomy, I'd much prefer to do that than a meniscal transplant to correct that problem.
Al, do you care to comment? Any rebuttal on that, or?
No, I fully agree. I think, and that's something I actually picked up a lot from Brian, is this concept of making someone meniscal dependent. And a lot of these people are coming back with a failed ACL. They don't have pain, and they want to get back to sport. And I want to give them a robust ACL. I will do a lateral tenodesis, which will reduce my forces on the ACL graft. It will have a bit of control of rotation. And I think that will hopefully be able to overcome some of the issues with the lack of anterior translation stability that you're getting from the meniscus. Because, as Brian said, 30% of patients may need to have a re-intervention, whether it's just a simple scope or not. That makes me very nervous about doing meniscal allografts in this active population. When you get into the sort of second, third revision ACL, then that's when you're maybe going to start doing everything you possibly can. But certainly in the first, I think in the first and second revision, I'm trying to avoid doing a meniscal allograft.
Do you mind if I ask Al you a question, or Seth? I think he may have said it, but what's your sense on the lateral side? I have had patients who have this sense of rotatory instability, but not necessarily pain, but a rotational thing on the lateral side when they lose their lateral meniscus. Most of the initial work by Barrett and others was on the medial side. Do you think we know enough in terms of the biomechanics to say that losing your lateral meniscus can screw up rotation and or the biomechanics of the lateral compartment, forgetting about pain? Do you think there's enough evidence to say that it is really important to maintain the integrity of the biomechanics of the lateral side?
I think, yes, I think we know enough from time zero biomechanical studies that the lateral meniscus plays a significant role in assisting the anterolateral complex and controlling rotation. The problem, I think, there is, can a lateral meniscus allograft reestablish those normal native kinematics?
Yeah, and at what price? Yeah, and at what price, like we talked about?
Yeah.
But I would say if I have a very sloppy knee, so an ACL and an explosive pivot shift, I'm looking for these reasons. So I think about slope. If I have a lateral root that I can put down in that kind of a patient, I'm extremely happy. Or I look for a ramp, as Al talked about. So or I had a tenodesis if I don't have those two things. So I'm always mindful that patient, that young, active, explosive pivot shift, if I don't have that clear root or ramp, then I'll add do the tenodesis and kind of, I'm always looking for a way to stabilize that knee better.
Brian, next question for you. You talked about osteotomy with meniscus transplant. What is your threshold? 3 degrees, 5 degrees? Does it depend on the degree of cartilage wear? What's going into your decision making for osteotomy with meniscus transplant?
Well, the smallest plate is a 5. So I'm not, if it's a 3, it's just not worth it. So I would say, I think someone's got their phone, someone may want to mute. I would say that if I can't benefit from a 5 or more, I'm not doing it, but my threshold is low. If there's any chondropenia on the tibia, if there's a cartilage problem on the femur, most of my meniscal transplants are not done in isolation. I think only 25% of my meniscus now are done in isolation. So they're usually with cartilage. So that is part of the decision-making. So I have a very low threshold with any cartilage work. If you just want to talk about isolated meniscus, I might tolerate a little more malalignment with isolated meniscus with no arthritis. It's really fascinating to ask the question, why do people even hurt if they're losing their meniscus and they have no arthritis? It doesn't make any sense, or edema or whatever, but that population does exist, but it's really small. So osteotomy with meniscal transplant with no chondral disease, maybe I want a little more malalignment. With chondral disease, my threshold goes down, but anything less than 5, I'm not touching. It's just not worth it. I don't overcorrect them. So if it's a 5 or more and it gets me to the other eminence, I'm good to go with an osteotomy. That's my answer.
Perfect. And then last question here, then I'll just show one case. Matt's given us the green light to go over a few minutes. Age cutoff for you, Brian, for meniscus transplants?
The challenge with age is that they tend to be physiologically worse than what you and I see to the naked eye as they get older. Those who come to us who have lost their meniscus, who are not out of bounds for being indicated, who are older, are typically just worse patients because I think they're really early arthritics. And I hate failure like all you guys do. So I don't do a lot of people over 40 because they're just usually have too much disease in my experience. Now, Kevin Stone has a pretty large series of patients that he's done with or without realignment, often without realignment. And his results are surprisingly good. But I feel like it's a operation that should be done. Like, I don't take the position that, look, this is a scarce resource and you got to pick the best patients. I think I probably undertreat and leave some people on the table that probably should have been operated on or could have been operated on. The problem with age is that it's associated with physiologic progression that you and I can't appreciate, and they tend to behave more like arthritics. And arthritics don't do well, in my experience, with meniscal transplants. So I try to really talk them out of it. If I have the perfect patient, I almost don't care what age they are, but I rarely see anyone over 45, for example, that doesn't have too much disease that I would consider at any age, for example. That being said, I've had bipolars who are 15 and 18 who I'll do a meniscus transplant all day long because that's all they got. And we've done surprisingly well. As I told you, if you treat the femur, even if they have a bad tibia, you can get a good result with a meniscal transplant and treat the femur and do what you want with the tibia. So not a
Brian,
sorry.
Brian, would you say that in your younger patient, if you go back to the previous question, you'd be more aggressive at doing an osteotomy combined with meniscus transplant?
Yeah.
But in the older patient, you'd probably push for doing an osteotomy alone and see whether or not you can get away without a meniscus.
Yeah, that's absolutely correct. I would have no problem doing cartilage in a young patient with the same disease you put in an older patient. Let's do osteotomy only. That's a very valid point.
Okay, we'll try to run through a quick case here. So 19-year-old, he's a college basketball player, has a right knee injury 6 months ago with a twisting injury, felt a pop. Since that time, he's had medial-sided activity-related pain and swelling. He's got some meniscal joint line findings on exam. So x-rays are normal. Seth, you kind of covered this in your topic. On the MRI, what are you seeing?
Yes, I'm concerned. I think it's what I'm not seeing. So I'm looking for his medial meniscus. We're concave, and I'm not seeing it on the sag. So it kind of ghost. And then I'm looking on the axial. And the more you get to see this, you're very concerned for issues near the root.
And more of the same. You see a lot of extrusion and a large truncation defect. Any other imaging you'd get on this 19-year-old college basketball player?
For me, I'm getting an alignment view at this point, given the chronicity and the concern for the root.
No before you go, right, buddy?
Absolutely, man.
So here's his scope pictures. You can see he's kind of got an avulsion of the root, and you can see through the notch a fairly large amount of gap that correlates well with the MRI. And unfortunately, at 6 months, he's got this rapidly, progressive cartilage wear of his medial compartment. So any thoughts on this one?
Well, I guess we're not going to discuss non-operative versus operative.
That ship sailed, Al.
Yeah, I think so.
We got 10 minutes.
So for sure, this young guy, root repair for me, his alignment is pretty neutral. So I would be thinking osteotomy. If he was in varus, interesting, I would probably aim for an offloading osteotomy, even though he's 19. There's limited data to say that these kids can't go back to sport. So I think it's more of a problem with regards his knee that stops people going back to sport rather than an alignment correction. And then for this, I do a transtibial repair, 2 tapes, and I would have a very low threshold of including a peripheral repair as well. So a peripheral suture with a second tunnel in the periphery as a centralization suture.
Yeah, so very good thoughts. So in this one, we did think about centralization because of the amount of extrusion. I like to use the Alps analogy in the shoulder. If we have a non-displaced Bankart tear, I think that's our root tear without extrusion. And if we have an Alps lesion in the shoulder, that's like our root tear with extrusion. And of course, we've learned in the shoulder, you have to release and advance and repair. And I think it's the same concept for the meniscus, except for the shoulder capsule ligaments, you're repairing the MT or the coronary ligaments. So here's just a quick technique. We release the MT ligament arthroscopically, both from an accessory anteromedial portal, from contralateral portal. And I do find that you do get increased mobility. Seth, I think you were alluding to this kind of in your talk. And then we are placing anchors for centralization through an accessory anteromedial portal, sometimes one anchor, sometimes two anchors, but the whole key is to reestablish the meniscus within the joint. So a variety of ways to pass sutures. I typically use mattress or oblique mattress sutures, but the key is you really want to directly visualize that meniscus back into the compartment. So here is just showing our meniscus being recentralized under direct visualization. So you can really see that extrusion being overcome. And I do prefer a knotless technique here. There's a variety of suture anchors on the market, but it just really leaves no, high profile knot stacks. And then you can really see the centralization that occurs. And then you just do a standard root repair, as Seth so nicely outlined.
Aaron, what's your threshold for not getting that root all the way to anatomic? What's more important, the extrusion and the centralization, or the root, or both?
I think there's probably a threshold of extrusion that matters. If you look at biomechanics, maybe 1 to 2, maybe even 3 millimeters of extrusion is reasonable. But as soon as you get over to 3 to 4 millimeters of extrusion, you're just not resisting hoop stress, when that meniscus is out of the joint. So for me, it's probably a spectrum, but anything over 3 millimeters, I think we have to correct.
Can I ask a decision-making question? Aaron, if you had a patient come to you with an MRI that you could safely determine had a radial split that went back to the popliteal hiatus, but had no extrusion and no pain and no swelling, and was fine clinically and doing everything, but you had an MRI because there was an event and they wanted to see what was going on, would you recommend fixing that in that setting? Or would you just say, come to me when you had symptoms?
So a full thickness radial tear of the lateral meniscus.
Say it goes into the popliteal. Say you're pretty confident that if you had some ability to test them at time equals 0, you might conclude that they had a non-functioning meniscus, which I say is akin to a root tear, a root tear, in my opinion. I think that's what we're talking about. Is like that's like a meniscectomized knee. So what would you do with the asymptomatic patient in that setting?
So I think those patients are rare, but I think that's probably a patient. You talked about the importance of alignment. Occasionally we'll see that knee, and that's probably a varus knee. Where they're loading most of their, medial compartment and not much in the lateral compartment if they're truly asymptomatic. So I'm not sure if we should be operating on asymptomatic, meniscus tears, even one, like that.
What about okay? Well, can I lock you in for a second then? Because I don't know, you may think I know the answer, but as I'm asking this question, I don't. I just think it's really provocative. So you just said you would not necessarily operate on asymptomatic. Right now, we all have these patients who have an event, they get a pop, they get swelling, and then they become asymptomatic, yet they have a root tear. And they even have extrusion. What is the narrative of that patient group? I'm going to mute so it doesn't echo. What do you say to that patient? I don't know the answer, and I'm listening to you guys trying to help decide what the right answer is.
I think if you're not going to operate on that person, you're watching them like a hawk. So it doesn't mean one or the other. It means see them back for pain effusion and maybe x-rays over time. But I think there's a difference between that medial radial split near the root in a maybe a little older patient and the lateral, complete radial resection in maybe an athlete. That's right now asymptomatic because they haven't done sport in a couple of weeks. I'm more inclined to fix the lateral one, and I'm not sure that's right or wrong, but I'm less inclined to fix the medial one if they're dry knee and asymptomatic.
Thank you.
So with that, I think we're 5 minutes over here. So thanks everyone. We had a great turnout for the session. 110 attendees. I saw the number go up to. So thank you very much for your participation. Reminder: there's a knee shoulder lab course coming November 14th and 15th in Rosemont at the Learning Center. Please register by October 24th. If you're looking for any other joint specific education, visit the AANA Learning Center online. And I'd like to really thank the panel. I think you've heard a lot of great perspectives, cutting edge experience. So thank you to Seth. Thank you to Al. Thank you to Brian. Again, thank you for our sponsorship this evening. JRF Ortho, Arthrex, DJO, as well as Kaibo Medical. And I'll leave you with an ad from our sponsors. But have a good evening, everyone, and thank you. Stay safe.
Aaron, before you play that,
Yep.
I know all the people on this webinar, and I will hunt you down if you're not members of AANA. So if you could please go to the AANA website. I expect to have all of you join AANA, and I expect to see all of you at our, and if the world is right side up, next year at our annual meeting, which we're going to announce very shortly when that's going to be. But just want to thank all of you for tuning in tonight. Hopefully this was valuable for you.
Thanks, Brian.
This is a field that's dealing with family crises, tragedies, death. You know, those are real things, and they're here, every single one of them, dedicated to making the most of what's a tragic situation for many families and turning that into a silver lining for another family. So, you know, I can't say enough good things about them. I feel lucky to have, you know, started to work with them and to be part of this family.